We're excited to present our work on objective bone conduction audiometry using our Sofi system with rapid cortical auditory evoked potentials. Our approach reduces bone conduction testing duration to under 15 minutes while addressing a critical gap in clinical audiometry for challenging patient populations. We've developed a novel EEG-based test for bone conduction that is fast, objective, and AI-powered to increase robustness to noise. The goal of our present study was to validate this BC-EEG approach against the clinical gold standard of conventional behavioral BC audiometry. This represents a significant advancement for populations who cannot reliably participate in traditional behavioral testing. Current behavioral audiometry testing faces significant clinical challenges, not only exclusive to bone conduction testing. Elderly populations show reduced cooperation due to age-related cognitive decline during testing procedures. Patients with cognitive impairments have difficulty following complex test instructions. Testing fatigue becomes a major issue as lengthy testing procedures become physically demanding for elderly patients. Additionally, unreliable behavioral responses affect diagnostic accuracy. This creates a critical need for objective BC testing that can provide comprehensive diagnosis regardless of patient cooperation limitations. Our foundation comes from previous validation of the Sofi system with rapid CAEP for air conduction audiometry. We successfully tested 10 elderly participants with asymmetric sensory neural hearing loss and 5 young normal hearing adults across 6 frequencies from 250 to 8000 Hz at both years. This established our rapid CAEP approach, which we published in the International Journal of Audiology. Our challenge was extending this proven technology to bone conduction, developing objective BC threshold estimation using the same rapid CAEP system and validating it against the clinical gold standard of BC pure tone audiometry. For this validation study, we collected data from 30 participants with asymmetric sensory neural hearing loss, a real clinical population ideal for BC validation. We tested BC thresholds at 500, 1000, 2000, and 4000 Hz on the poorer hearing ear using our 8-channel semi-dry EEG electrodes with 12.5 minutes per assessment and 5 dB HL precision. The semi-dry electrodes significantly reduce setup time and patient inconvenience compared to traditional gel-based electrodes. We compared 3 methods. First, conventional PTA using B81 radio ear bone transducer with 1 to 3 second pure tones and Hughes and Westlake procedure. Second, our rapid CAEP system using the B81 radio ear bone transducer but with 30 millisecond pure tones presented pseudo-randomly at 5 Hz. And third, auto-bear, a behavioral control condition using a modified Hughes and Westlake procedure and the same 30 millisecond stimuli as Sofi with rapid CAEP, serving as our calibration reference to account for systematic differences between stimulation modalities. Our analysis reveals systematic differences between the 3 methods using orthogonal distance regression. When comparing Sofi with rapid CAEP and our behavioral control using identical 30 millisecond stimuli, we found intercepts very close to zero across all frequencies with R-squared values greater than 0.79 and highly significant at less than 0.001. This validates that there's no systematic offset when using identical stimulation. However, comparing PTA with our behavioral control revealed larger intercepts up to plus or minus 10 dBHL. This systematic difference is related to the stimulus characteristics as shown in the regression plots. Our calibration approach, which was developed for air conduction to account for stimulus length differences, may have overcorrected for certain frequencies in bone conduction. To properly correct for these systematic differences, we use the behavioral control PTA regression to adjust our EEG estimated thresholds. After applying the systematic offset correction, our results demonstrate strong validation of the rapid CAEP approach for bone conduction audiometry. We achieved a strong Spearman correlation between Sofi with rapid CAEP and PTA with a correlation coefficient of 0.65, highly significant at less than 0.001. These correlation plots show the results after systematic offset correction, demonstrating consistent performance across all 4 frequencies tested with a mean absolute difference of 9.33 dBHL. In conclusion, we've achieved 3 key findings. First, a strong correlation between Sofi using rapid CAEP and BCPTA thresholds. Second, agreement with BCPTA with a mean absolute difference of 9.33 dBHL after systematic offset correction. And third, validation that our EEG-BC measurements align with behavioral responses and that the systematic differences with BCPTA stem from stimulus properties, not from using EEG-based measurements versus behavioral testing. These results demonstrate the clinical feasibility of objective bone conduction audiometric assessment using rapid CAEP technology in just 12.5 minutes with semi-dry electrodes. While elderly populations with cognitive impairments and attention deficits can be tested reliably using ABR or ASSR, the major drawback is testing time. Our main advancement is obtaining these reliable results with a 12.5-minute assessment, making objective BC testing much more practical for challenging populations. We have ongoing studies on BC testing in pediatric populations, BC with masking conditions, and test-retest reliability that we'll be sharing results from in the near future. Thank you very much for your attention, and I'll be happy to answer any questions you may have.